Let's dive right into the Step 2 CK explainer, covering high-yield, symptom-to-algorithm clinical pathways for breast, menopause, and pelvic floor presentations.
We'll be walking through palpable breast mass workups, benign breast disease, lactation complications, menopause, and finally, prolapse and incontinence management.
Starting off with the palpable breast mass workup and specifically how age drives your evaluation.
When a patient presents with a palpable mass, their age is your absolute compass here. For patients under 30, ultrasound is usually your first step. For patients between 30 and 39, you're often looking at a mammogram plus an ultrasound. And for those 40 or older, it's a mammogram plus an ultrasound because the breast tissue is less dense. But remember, the diagnosis of a palpable breast mass can only be confirmed with a biopsy. If the physical exam is highly concerning, you need to proceed with a biopsy. Specifically, a core needle biopsy is preferred for suspicious solid masses, even if the initial imaging looks reassuring.
Now, if that ultrasound shows a simple cyst, your next steps depend on symptoms. Asymptomatic patients? Just observe them. But if the cyst is tender, you'll do a fine needle aspiration. If imaging reveals a complex cyst or a solid mass instead, bypass the aspiration and go straight to biopsy. Oh, and keep in mind that fat necrosis, which can happen after trauma or surgery, can actually mimic cancer by presenting as a firm, irregular mass or showing calcifications on imaging.
Let's say you do that fine needle aspiration on a tender cyst. If you get clear, non-bloody fluid, and the cyst completely resolves, your next best step is simply to repeat the breast exam in 2 to 4 months. Cystic fluid can reaccumulate, so if there are no signs of recurrence at that checkup, they can just resume routine annual screening. Conversely, if the fluid is bloody, or if the cyst is recurrent or persistent, that demands imaging and a biopsy.
Moving on to benign breast disease and nipple discharge.
You'll often need to distinguish between fibrocystic changes and a fibroadenoma. Fibrocystic changes present as multiple, diffuse, cord-like nodulocystic masses, usually with bilateral cyclic tenderness right before menses. You treat this conservatively with a supportive bra, NSAIDs, and reassessment after menses. On the other hand, a fibroadenoma is a single, unilateral, mobile, firm, well-circumscribed mass typically found in women under 30. For an adolescent presenting with a classic fibroadenoma, observation is the indicated next step, but persistent masses do need to be imaged.
When a patient complains of breast pain, vocality is everything. If they have focal unilateral non-cyclic pain with an actual mass, you absolutely have to get targeted imaging and a biopsy. But if it's bilateral, diffuse, cyclic pain without a mass, that simply requires observation.
For nipple discharge, your first job is splitting it into physiologic versus pathologic. Physiologic discharge is usually bilateral, multiductal, and only expressed when manipulated. This warrants a galactorrhea workup. Check a pregnancy test, prolactin, TSH, do a medication review, and evaluate the pituitary when indicated. Pathologic discharge, however, is spontaneous, unilateral, and bloody or serous. When you see that, you need to jump to strict age-based imaging, followed by a biopsy.
A highly tested cause of pathologic discharge is the intraductal papilloma. This is a benign papillary tumor in the duct lining that classically yields spontaneous, unilateral bloody fluid, but notably without a palpable breast mass or lymphadenopathy.
Let's shift to lactation and postpartum complications. Right off the bat, if a patient has nipple pain, abrasions, cracking, and maybe even some bloody discharge, suspect a nipple injury from a poor latch. You manage that simply by observing the feeding and correcting the infant's lap.
Now for the internal complications, look closely at the presence of a fever. Fever immediately separates mastitis and abscesses from things like engorgement, plug ducts, and galactoceles. Engorgement occurs when the milk comes in, causing bilateral symmetric fullness that improves with frequent feeding. A plug duct is focal but, crucially, has no fever. A galactocele is a mobile, subareolar milk retention mass, again, no fever. Fever and myalgias are what point you directly to infectious mastitis.
So, mastitis gives you a firm, red, tender, swollen quadrant. For treatment, give analgesics, antibiotics targeting skin flora, and have the patient continue frequent breastfeeding or pumping to clear out that stagnant milk. An abscess looks very similar but adds a focal fluctuant mass. Once you suspect an abscess, an ultrasound is required for diagnosis, and management steps up to include antibiotics plus direct drainage.
But what if you have a patient with unilateral breast warmth, redness, and swelling? They do not have a fever, and they completely fail to respond to a course of antibiotics. That is a massive clue for inflammatory breast cancer. You'll often also see that classic PU d'orange appearance from obstructed dermal lymphatics. All right, let's transition into menopause and genitourinary syndrome.
When you see this classic combination, systemic vasomotor signs like hot flashes and sleep disturbance, alongside pale vaginal mucosa, decreased rugae, and a vaginal pH greater than 5, you are looking at menopause. High levels of FSH are characteristic here due to the loss of ovarian feedback, though you'll typically make this diagnosis clinically. We manage mild vasomotor symptoms with behavioral modifications. But for moderate to severe symptoms in recently menopausal patients, we use systemic hormone therapy. However, if there are any contraindications to estrogen, like a history of coronary heart disease, thromboembolism, or breast cancer, you have to pivot to non-hormonal therapy with SSRIs.
Then we have the genitourinary syndrome of menopause, or GSM. This causes vulvovaginal dryness, burning, dyspareunia, recurrent UTIs, and that elevated pH we mentioned, all due to local estrogen deficiency. You can start with moisturizers and lubricants, but the specific medical next best step is topical vaginal estrogen. This treats the local atrophy without systemic estrogen exposure.
Let's wrap up with prolapse, incontinence, and fistula management.
Pelvic organ prolapse, whether it's a cystocele, rectocele, enterocele, or uterine prolapse, causes pelvic pressure, a noticeable bulge, and often obstructed voiding or constipation. Treatment starts conservatively with weight loss and pelvic floor exercises, then advances to a vaginal pessary, or ultimately surgical repair. Note that a procedure called colpoclesis can be used in older patients who no longer desire vaginal intercourse.
If a premenopausal patient presents with dyspareunia but lacks any mucosal atrophy and their external pelvic examination is entirely normal, suspect genitopelvic pain/penetration disorder, which is also known as vaginismus. This is an aversion to intercourse due to involuntary muscle spasms, and it's managed behaviorally with desensitization therapy and Kegel exercises.
Let's break down incontinence. Stress urinary incontinence, leaking when you cough or laugh, is treated with pelvic floor therapy, a continence pessary, or a mid-urethral sling. Urge incontinence causes urgency and frequency. You manage that with bladder training and antimuscarinics or beta-3 agonists. Overflow incontinence causes constant dribbling and retention from bladder atony, which requires intermittent catheterization. And a quick pro tip, in older patients presenting with acute incontinence or delirium, always check urinalysis and culture first.
In the postpartum setting, urinary retention presents with an inability to void or continuous dribbling, often after prolonged labor or regional anesthesia causes pudendal nerve damage. Also be on high alert for postpartum fistulas. A vescovaginal fistula causes continuous, painless urine leakage after pelvic surgery, radiation, or prolonged labor and is diagnosed with a dye test or cystoscopy. A rectovaginal fistula causes flatus or feces to pass from the vagina, often after obstetric trauma, radiation, or Crohn's disease.
Anchor your clinical logic to these specific thresholds: the exact age cutoffs for imaging a breast mass, the presence of a fever separating lactation issues, the specific leakage patterns of incontinence, and the timelines of postpartum voiding. Locking down these precise branching pathways is exactly what dictates the next best step in management on exam day.